And my name is Anna Goddard. I am a Project ECHO faculty for SBIRT and School-Based Health Centers for the School-Based Alliance. And today I was asked to speak about training and assessing your staff around the components and implementation of SBIRT and how to support your providers in the work that they're doing around implementing SBIRT in your school-based health center. I have no commercial disclosures or conflicts of interest. And these are the objectives today, but I would like to go right into objective 1, which is to review the options for initial and ongoing training for clinical providers regarding SBIRT. So with implementation of any intervention, training and assessment of your providers are critical to the work that you're going to be doing, but also the sustainability of your work. So some key points to keep in mind as we move forward today is that you're going to want to develop training and assessment that is unique and tailored to your own staff at your own school-based health center site where you're conducting SBIRT. You know your organization best, as well as your staff and the strengths and limitation of the system that you're working in. So what is important is that you have the ongoing training for your staff that is specific for you and your program. Conducting booster sessions in consideration of how to review and refresh your staff on SBIRT is just as important. Your booster sessions are critical forums to address the barriers and challenges your staff might be having regarding SBIRT and having your team complete the booster trainings. This creates not only tracking of who received the training, but accountability both for the employee or the staff member, but also the supervisor and your agency that are providing the training. And ultimately, this supports your staff. Experience and research has shown that the importance of using different training techniques, both for your initial and your booster session, is needed. You're going to need to appeal to your visual learner, but also the oral and kinesthetic learner. So different approaches and pedagogies are going to be needed. You can't just hand someone a binder or a manual and then check your box, oh, we train them on SBIRT. This isn't the best way, we know from research, to do this training. A standard lecture and upfront information-based learning, of course, has merit, but you're going to also need to approach the different skill-based training to include demonstration and role play, and then working through case studies. And these have all been very valuable in teaching methods with SBIRT. So as you prepare your customized training for your organization, you want to keep a few pieces of implementation in mind. You want to make sure that your initial training is comprehensive and detailed, and that you're providing and covering as much information as necessary to complete the work, but also have your staff be able to go back at another time if needed as a resource or reference for any support in the future. You want to make sure that you highlight the most important pieces of SBIRT, include the roles for all the staff members involved and your providers at your school-based health center site, and then give helpful tips and instructions for success at your program. We recommend to have screenshots from your own EMR or EHR on where they should be documenting in their health record. Be very clear on how to outline how SBIRT fits into the workflow at your company. And understand that even if a new employee, quote unquote, knows SBIRT from another organization, you still really need to make sure they understand the expectations specific for your own school-based health center. Finally, do not forget to provide the training for specific skill sets for SBIRT, and usually that is your motivational interviewing component. Different providers have varying levels of comfort with MI, and practicing MI in the SBIRT context is really important as part of that initial training. Some considerations for your booster sessions include reviewing the documentation and charting with your staff. This can be a time for your team or your team lead to identify the challenges and barriers for SBIRT at your school-based health center. So for example, a simple issue of not clicking the correct box in your EMR, it might suggest poor performance by your staff. But if your providers may be actually providing these services and they're just not documenting where you want them to document in your EMR. So this can be a checks and balance system. Your booster trainings are also very helpful for skill building, especially with screening and debrief intervention, and providers can have experience in speaking out and relating to peers around real life cases. And that only further enhances and develops their own SBIRT skills. It is also really helpful to share your outcome data with your staff that are providing the SBIRT work. Share that data and use that data as a benchmark, both for internal staff members and internal successes, and then highlight any areas of improvement for your staff. A specific note about training related to the screening piece of SBIRT: do not assume that your staff know the specifics of the screening tools and the screening steps as it relates to SBIRT. Even if your organization has previously used the screening tool in the past, like the PHQ-9, make sure everyone on your team is very familiar with how to administer and then score the screening tool. Be very clear on the frequency of the use for your patients or clients at your site, and what the expectations are in regards to how often your staff are going to be doing the screening for SBIRT, because everyone kind of sets that up a little differently. For example, every patient every day, or maybe your school-based health center is going to focus on, at least one student every year, or you want universal screening. So this is where a process mapping is really particularly valuable in implementing SBIRT, and that really irons out all those specifics for your staff to make sure everyone's on the right page. Finally, make sure everyone is clear on what constitutes a positive screen, and that everyone is on page with where to document those positive screens. Make sure that the documentation for the screens are able to be pulled, that they've been followed up on. You don't want to miss a student who was screened positive for depression or substance use, and then for whatever reason didn't have the appropriate flag for a follow-up for that student, because this can create a lot of liability for your organization and is obviously not best practice for the students. So it's very important to include that in your training with your staff. In regards to the educational material, make sure you give hard copies to your staff of key materials, and then keep those electronically on file somewhere at your organization, whether you have a shared network or a Dropbox folder that all your providers can access whenever they need it. Some really good hands-on to have for staff include the standard drink charts showing what one drink is versus the other, and I have that as a resource for you at the end of this presentation, as well as the readiness roller for MI are really nice to have on hand in a handout. The fact sheets on substance use are very important, and be mindful that you keep these up to date because they change so rapidly in the field. And at the end of this presentation, I have that reference if you need to pull that as well. Other suggested resources to have in print and digitally for your staff to reference at any time they need include the brief intervention steps to take when a student is substance using. So the MI skills cheat sheets are very handy to have in a folder at your sites, especially if a provider is just starting or is new to the motivational interviewing piece. They might want to reference this in between student visits to give themselves a little reminder, but also remember to make sure you have all your patient handouts in Spanish, or in another, at least Spanish at minimum. Finally, it can be very helpful to have a little note card or a cheat sheet on hand with the appropriate billing codes and CPT codes that you're using for SBIRT, especially if that's how you're going to be pulling the data. So next, we're going to review some of the assessment pointers and resources to assure that you're adequately assessing that SBIRT components are being implemented the way that you train your providers to implement them. So in order to best assess your clinical providers on how they're doing with SBIRT, you're going to be monitoring and assessing not only their progress in terms of conducting the work, but also the actual fidelity to the model of SBIRT itself. And this is just a very simple checks and balances method, as they might be able to additionally catch their numbers being off, or adequately, maybe their numbers aren't being reflect with what they know they're doing. And so then you can look at the data and IT on where that might be happening, and hone in on IT working with you to pull data, or making sure your providers are documenting the data where you want it to be pulled. This is also consequently an example of quality improvement and quality assurance working together in your clinic in terms of assessment. So when your providers are newer to your team, you might want to assess them a little more regularly, or do check-ins monthly as it relates to SBIRT. If they need more support or training on one or more components of the training or of the screening, or of the BI or of the referral process, you can then use your assessment as a check-in on how effective that protocol is being implemented, because they have really a new set of eyes on the system and on everything. And it's important to get that feedback from those providers. So in regards to fidelity of the model, consider how often you want to do assessment with your team, quarterly, maybe monthly for some of your new staff. And at a minimum, you really want to consider adding SBIRT skill competencies as part of your annual OPPE, and that's the ongoing provider proficiency evaluation, is what it's usually called, in short, OPPE. That's done for clinical employees. So consider the fidelity of the model as well as the protocols that you set up at your practice for implementation when you assess. SBIRT assessment of the providers should be competency-based, meaning that the observation of specific skills as it relates to screening and brief intervention and treatment is being done, and not just an assessment of, yes, they're doing SBIRT. It really needs to be competency-based. Perhaps more easily assessed is your documentation standards for your agency. And as I mentioned previously, assessing documentation can really help pinpoint where a breakdown in your system occurs, but also in regards to fidelity of SBIRT components being conducted at each of your sites. You can do this through the typical supervisory review and assessment with your team members, or you can create a peer review system where your providers assess one another, maybe one time a month at the end of a meeting, or you can build this into your EMR review, into your quality assurance for your program or for your company. So next, I'm going to finish up here by just very briefly reviewing the structural and mental health support for clinical providers regarding SBIRT implementation. And believe it or not, a lot of what we just reviewed are the more concrete foundational work of supporting your providers. Through adequate, appropriate training and assessment, you're also supporting them. So providing these resources are needed for them, and then just as important, recognizing the need that they're, or the work of what they're doing in the field. But I want to take a little bit of time and reflection on the promotion of self-care and recognizing compassion fatigue with your providers. We've heard a lot of this related to COVID, but also to recognize this as a potential outcome of your staff who are doing SBIRT. We found that while mental health clinicians are pretty well grounded in topics around compassion fatigue and compassion satisfaction, as well as vicarious traumatization, which can occur anytime you're caring for someone outside of yourself, with the increase in mental health services being done, including those screenings for depression and suicide and substance use, it really starts to open up windows in students' lives. And some of your other team members, like your medical assistant or RN or APRN, they might not be, or any of your non-behavioral health providers, they might not be as well versed in the quantity of depression screens that can open up compassion fatigue with your staff. So one of the points that I really just want to normalize and recommend that you normalize to your staff is that compassion fatigue is normal. It just happens, just as it happens in nurses and behavioral health clinicians, it happens with a lot of other practitioners in the field, like counselors, educators, police officers. Really anywhere where there's any sort of empathic engagement with a patient or a client, this is going to happen. And so when you're screening youth for depression, anxiety, and substance use, and then referring them for mental health, this is a result of that reaction from that patient care disclosure, and should be expected that it might happen. So with that, it's really important that somehow you show your staff that experience a reaction from patient care or from a patient disclosure that that's normal and should be expected as part of doing this work. As an administrator and a provider, be familiar with the compassion fatigue recognition, which is ABCs, your awareness, balance, and connectedness. When we refer to awareness, you really want to be tuned in with any possible symptoms of compassion fatigue, some of which might look like depression, sleep issues, anxiety, hopelessness, verbalizing any of those kind of things in the work or in their field. But remember, it also might be less concrete and easy to identify as compassion fatigue. It might be a slow feeling of overwhelmed at work, or feeling apathetic or more disconnected to clients than usual. Components of SBIRT were previously very stereotypically described as mental health work, right? The screening and things like that. But so be really attuned to your medical and nursing staff who may have difficulty with this. So creating awareness among your providers, but also among all of your administrators. Creating balance, B is balance in the ABCs of compassion fatigue, is often reported as the most difficult to do. But the best way to create balance is to set limits for yourself, set a goal, and when it's accomplished, give yourself time for rest and release from that work. As administrator, you can support your employees and actually reduce turnover by allowing them the balance between work and life that many employees strive for in the workplace. In fact, research has shown that employees value work-life balance sometimes more than salary or any monetary compensation. We're no longer living in a society that the workplace should celebrate employees who never take PTO or never take sick time or vacation day. And as we know, those are your employees that end up being less productive and less effective in the long run. So finally, the C in combating compassion fatigue is connection. As humans, we're neurobiologically hardwired for connection. So connection can be to people, to organizations, religious communities, spiritual experiences. But remember, when you're feeling the most fatigued and the most exhausted from work is usually when we self-isolate. But this is really when you need to reach out and make connections the most. So this is just really a quick reference, but also a resource on grounding yourself with self-care activities that include connection to yourself and connection to others. And these are activities that you can offer to do for yourself at home or at work. So finally, I'm going to end at the easiest, but one of the most overlooked ways to support your staff, and that is through recognition of their work. When you look at sustaining any intervention in EBP in the field, you need to disseminate the results of the work you completed and then recognize your staff that completed it. So internal recognition and gratitude can go a very long way, but this is also evidence-based in the literature. Ending with a staff celebration, some sort of recognition of the work that your team accomplished. This is all just as important as the other strategies I mentioned in training, assessing, and then supporting your staff. So if you have any questions, please feel free to email me at any time. And then at the end of this presentation, I moved here's my references. I moved some support slides for you guys to access on your own regarding awareness videos for training, online simulation options like Cognito. The American Academy of Pediatrics has put out a guide for SBIRT that you can access and log into. NORC has an SBIRT training guide that's available on their website, and those links are here for you. This is the Institute for Research, Education, Training, and Addictions, and they update their SBIRT work regularly. This is the Adolescent SBIRT Toolkit for providers that you're able to access through Massachusetts Department of Public Health, who incidentally has implemented SBIRT in schools across their entire state as a requirement for all schools, regardless if they have a school-based health center or not. You can look up different case studies for training at both of these references. These are different role play suggestions and areas to look into. And then finally, some assessment resources. You can actually assess your providers for competency-based with Cognito. And then that is it.